Good evening, everyone, and thank you for listening tonight. Apologies for some minor delays. Tonight, I will talk to you about a very fascinating and oftentimes missed disease called celiac disease, and I'm going to just dive right into it. So, my presentation will start with a case study. Um, sorry, and it's a very interesting case that we had in the laboratory in recent times. It's of a 52-year-old female patient with a 12-year history of severe chronic fatigue, abdominal discomfort, intermittent diarrhea, and constipation. She also presented with a late onset of epilepsy. The patient had recurrent upper respiratory infections during her late childhood and early adulthood, as well as severe sinus infections, and was diagnosed subsequently with a total IgA deficiency. In her reproductive years, the patient suffered from infertility-related problems and had an endoscopy almost a decade ago, which at that stage showed atrophic duodenal mucosa and a thick lymphoplasmacytic infiltrate. A diagnosis of duodenitis was made. The patient at that stage had extensive laboratory and imaging investigations performed. Globally, wheat-free and gluten-free products and diets have become fashionable, indicating at first glance that the prevalence of gluten-related disorders are actually very high. Best-selling books, fad diet, social media influencers, fitness experts, and even the lady next door will promise you that going gluten-free will solve all your health-related issues. Clinicians are therefore often confronted with patients who suspect that they may react to wheat or to gluten, and most patients will attribute these adverse reactions to an allergy. It is a great challenge to our clinicians to distinguish between the different gluten-related disorders like celiac disease, wheat allergy, a wheat intolerance, or even the more serious conditions like chronic inflammatory bowel disorders, of which ulcerative colitis as well as Crohn's disease form part of. Tonight, I will walk you through celiac disease, talking a bit about prevalence, pathogenesis, as well as all the rest. And I will end the talk off with just a little bit of a note on how to distinguish between celiac disease, a wheat allergy, and a wheat intolerance, and how to know the difference. So celiac disease, in essence, is an autoimmune disease, and it's very important to remember that it is a multi-system disorder with a very wide range of clinical manifestations, and it affects particularly your small intestine. It is known as a gluten-sensitive enteropathy and is a common immune-mediated inflammatory disease of the small intestine caused by a sensitivity to dietary gluten and related proteins in genetically predisposed individuals. The offending antigen is gliadin, which is from gluten consumption, and it activates your innate as well as your adaptive immune response, leading to an intense inflammatory reaction, which is characterized by an infiltrate of lymphocytes in the mucosa of the small intestine. So what is gluten? Gluten is a collective term, and that is for wheat, rye, and barley, and it consists of proline and glutamine residues. So it's very important that the gastric and the pancreatic enzymes are unable to break down these proteins, and the proteolytic stability of the gliadin molecules is key for the immunogenicity of celiac disease. Prevalence of celiac disease is thought to range anywhere from 0.5 to 2% of the general population, with an average risk of 1%. In countries like Sweden, it's even higher, where the incidence reaches high levels of 3%, with very low levels in the East Asian countries like Japan and Vietnam. And the reason for that is that cereal is not considered to be a staple food in that area, as well as your genetic HLA alleles, the DQ2 and the DQ8 is not prevalent in that area of the world. It is considered one of the most common lifelong disorders and can affect people of all ages, but it is more commonly seen in females. So I'm sure you have seen this picture before, and what it depicts is the celiac iceberg. And it is where the tip of the iceberg is the patients that we actually diagnose with celiac, and the area under the water is the undiagnosed celiac disease patients. It's important to know that although they present with atypical symptoms and the diagnosis is delayed, the villus atrophy and the damage to the intestine is continuing. 70% of all celiac disease patients will escape diagnosis. However, the tip is getting bigger. So why is the prevalence of celiac disease on the rise? Are we diagnosing more celiac disease because of increased awareness? Or is there a lower threshold of clinical suspicion? Or is the increased availability of serological testing increasing the prevalence of these tests? And the answer is that it is actually both. We are diagnosing more patients with celiac disease, but the prevalence is also increased. A study was done in 2009 and was published in the Journal of Gastroenterology, and it looked at patients in the European countries in the 1950s. At that stage, serological testing was not available, and we tested the serum then of these patients and compared it to serum of patients in the current millennia, and they found that there was almost a doubled increase in the diagnosis of celiac disease currently. The prevalence seemed to have increased dramatically in the United States during the past 50 years, and other countries like Israel has showed a decreased incidence. Undiagnosed celiac disease is also associated with a fourfold increased risk of death as compared with people who are not serologically positive for celiac disease. So the average time of a diagnosis can be delayed by up to 13 years. And for every adult case that is detected, it is almost estimated that there are 8 cases missed. We should know that people living with celiac disease have associated higher morbidity and mortality. And the easy answer is just a gluten-free diet, where we can improve their quality of life and prevent serious illness. Now I'm going to quickly discuss the pathogenesis of celiac disease, which might seem daunting, but once you understand how the disease works and the reason for the disease activating your innate and your adaptive immune response, you'll understand how the symptoms can vary so widely and how therapeutic advances have been made in the clinical world. I've taken this image from the New England Journal of Medicine, published in 2007, and it depicts the whole pathogenetic process of celiac disease, where the patient ingesting gluten in a predisposed individual will have increased epithelial junctions in the gut mucosa. This gluten peptide fragments will then pass through the epithelial barrier of the small intestine, and it will enter the lamina propria, where it is deaminated by an enzyme called tissue transglutaminase, which converts the glutamine to the glutamine residues, imparting this negative charge to the particles. Antigen-presenting cells, often dendritic cells or neutrophils, then present these deaminated gliadin peptides to CD4 T cells present in the lamina propria. This activates the adaptive immune system and skews it towards a T helper 2 environment. Pro-inflammatory cytokines are released, which also then stimulates B cell differentiation and its secretion of autoantibodies. And this forms the hallmark of celiac disease, is testing for these autoantibodies against the enzyme tissue transglutaminase, as well as against the deaminated gliadin peptide molecules. The cytokine release in this milieu also stimulates proliferation of intraepithelial lymphocytes, which then causes degradation and atrophy of the duodenal mucosa and villus atrophy and death. This is the hallmark of the histological testing that we perform to help us make the diagnosis. So often in medical school, we were taught that celiac disease presents like the picture depicted on the left. It is children who will look with like patients with a distended abdomen, they have failure to thrive, they are emaciated, and have chronic diarrhea, where in reality, this is actually the exception and not the rule. I've divided the clinical presentation into three categories, where you have your classical celiac disease signs, which often presents in patients under the age of 5 years. They have chronic diarrhea, loss of appetite, abdominal distension, weight and muscle loss, and can even have emotional changes. In third world countries where the diagnosis is delayed and not made early enough, children can present in a celiac crisis, which is often seen where they are in a hypovolemic shock due to the chronic diarrhea and dehydration. There could be electrolyte malabsorptions, hypoalbuminemia, hypertension, and lethargy. The non-classical symptomatology is the most common that we will see in our private practice as well as in general practice, and these are the patients that present with a non-specific gastrointestinal complaint. They have recurrent flatulence, recurrent abdominal pains, diarrhea, and constipation. Oftentimes, on the blood results, the iron deficiency anemias, vitamin B12 deficiency, vitamin D deficiency, as well as zinc deficiency is picked up. Patients present with chronic diarrhea, recurrent aphthous ulcers, hair loss, bone pain, and the rash, which I will talk about a little bit later in the talk. And then the infertility issues, which is significant. Females diagnosed with celiac disease often have a delayed puberty. They can present with a later menarche, and in their reproductive years, they can suffer from miscarriages, premature birth, small for gestational age, and excessive and recurrent fetal losses. I feel that if fetal losses can be probably avoided in these patients when screening for celiac disease is instituted in infertility clinics, as well as in your gynecological clinics and maternity wards, especially given that it is diagnosed in 10% of females suffering from recurrent miscarriages. The subclinical group is the silent group, and often these patients are picked up when they go for celiac disease screening, when they have an at-risk family member, and retrospectively, most of them will attribute a lot of their symptoms to the diagnosis. Celiac disease can be associated with other autoimmune diseases, especially your type 1 diabetes, autoimmune thyroiditis, autoimmune hepatitis, primary biliary cirrhosis, and other connective tissue diseases like SLE and Sjogren's. And it is said that type 1 diabetes and celiac disease share a multiple genetic loci, not only the HLA-DQ2 and DQ8, but other HLA loci and other genetic variations. This suggests that celiac disease and type 1 diabetes have common features in their pathogenesis and includes tissue damage from the autoimmunity as well as the intolerance to dietary antigens. Patients suffering from celiac disease have an increased risk of developing inflammatory bowel disease, where the risk is 3.96 times higher than the general population and is often seen with ulcerative colitis more than Crohn's disease. There are two small independent studies that found a common pro-inflammatory polymorphism of the interleukin-23 receptor on both ulcerative colitis and celiac disease patients. In our case study, the patient also had a selective IgA deficiency, and it has been reported to be up to 8% of patients with celiac disease. We often see atopic dermatitis, esophageal reflux disease, Down syndrome, Turner syndrome, and then a lot of neuropsychiatric symptoms is reported in patients with celiac disease. And these can include anything ranging from headaches, peripheral neuropathy, ataxia, epilepsy, depression, dysthymia, and anxiety. If we quickly just look at the rash that is associated with celiac disease, it's called dermatitis herpetiformis. And what it is, it's an uncommon autoimmune cutaneous disease characterized by blistering papules and vesicles, often found on your forearms, knees, buttocks, and on the scalp. More than 90% of patients with dermatitis herpetiformis have small bowel biopsies that is consistent with those patients that have a gluten-sensitive enteropathy. IgA antibodies are thought to be deposited in the epidermal layer, and patients often demonstrate the same manifestations as those patients with celiac disease, and a gluten-free diet is recommended, which sees a relief of this rash. If not, another therapy like dapsone can be instituted. Now we get to the genetic predisposition, and the important molecule here is the HLA molecule, or the human leukocyte antigen class 2. So patients with celiac disease often have a family history, and if you have a first-degree relative with celiac disease, your chance of developing the disease is 10 to 15 times higher. The molecules responsible is DQ2 and DQ8, which is the class 2 found on all antigen-presenting cells, and it is not sufficient to cause the disease, but is almost found in all patients with celiac disease. So DQ2 and DQB1*02 are almost synonymous, and I'll explain why now. So the class 2 molecules consist of an alpha chain and a beta chain, and they are encoded by genetically linked HLA DQA1, and these isoforms are often nicknamed in the lab 2.2 and 2.5, and it's just the alpha part of the class 2 molecule that differs in its allelic type. DQ2 represents the second highest risk factor for celiac disease, with the highest risk factor being a close family member. And due to its link to celiac disease, DQ2 has the highest association of any HLA serotype with autoimmunity. Close to 95% of all patients with celiac disease have a HLA DQ2, and patients with DQ2 homozygosity, meaning you have a DQ2 positive on both your alleles, have a lifelong risk of between 20 to 40% of developing celiac disease. So the negative predictive value of the test is actually the important thing, that the negative DQ2 and DQ8, that the risk is very low. A study was published, a review article in the Lancet this year in June, that shows that less than 1% of cases will be negative for DQ2 and DQ8. A positive result, on the other hand, does not confirm the diagnosis, as DQ2 especially is a very common and frequent allele seen in the population, especially your European populations. The ESPGHAN guidelines that was updated in 2020 advised that DQ2 and DQ8 typing is not required in patients with a very high antibody level and a biopsy that shows there is atrophic villus formation, and as well as EMA positivity. But I'll go through the diagnostic criteria a little bit later. So why do HLA testing, and when to do HLA testing? So first-degree relatives of those suffering from celiac disease, we would recommend that they go for HLA testing, because if it's negative, the risk of developing celiac disease is almost absent. You can also employ HLA typing when you have a diagnostic dilemma, meaning the serology and your biopsy, the results differ or they are borderline, or with patients who are already on a very strict gluten-free diet where the diagnosis of celiac disease was never confirmed. So now we go into the interesting part for me working in a laboratory, and that is the serological testing of celiac disease. So worldwide, it is seen as the first line of testing in patients with suspected celiac disease, and the three main antibodies is the antibodies of IgG and IgA against the enzyme tissue transglutaminase that I explained in the previous slides, that deaminates the gliadin peptide, antibodies against endomysium, which is found in the lamina propria of the gut, as well as antibodies against the actual deaminated form of gliadin. So a positive antibody against tissue transglutaminase or endomysium is associated with a very high probability of celiac disease. Isolated low findings of TTG has been noted in other autoimmune conditions, which includes tumors, infections, myocardial damage, liver disease, and psoriasis. But if your anti-TTG level is very high, and especially when it's above 10 times the upper limit of normal, that usually correlates with the villus atrophy and should be used as an initial approach in the diagnosis of celiac disease. I'm going to quickly talk a little bit about all these antibodies separately. And anti-tissue transglutaminase is that autoantibody directed against the major celiac disease antigen. It is the enzyme responsible for deaminating the gliadin. And it's important to note that most laboratories can test IgA as well as IgG subclasses. The sensitivity and the specificity is excellent, is more than 95%, and it's considered to be the first line screening in celiac disease. Whereas endomysial antibodies is IgA antibodies or IgG antibodies directed against tissue transglutaminase 2 in the endomysium. So the way in which we test these antibodies is by indirect immunofluorescence, and we use tissue sections, often of primate. So we use the primate esophagus or liver, which you can imagine is a scarce resource, and recently they've been using human umbilical cord substrate. The test is 100% specific, but due to the intraoperative variability, is not considered to be your first-line test, but an excellent confirmatory test. You need skilled personnel and a laboratory that is very good with immunofluorescent microscopy. This is just a picture to show you how it will look under the microscope. In the left-hand corner, you'll see a positive result where there's apple green fluorescence of the endomysium. And on the right-hand corner, a negative EMA, even though you see a little bit of green, the black areas represents the endomysium. As you can see, equivocal results occur as well as patients who are IgA deficient, and that's why it's very important to have skilled laboratory pathologists or technicians to make the diagnosis, and it's reported as positive, negative, or equivocal. If we look at anti-deaminated gliadin peptide, IgA and IgG is helpful in patients who are negative for TTG, but with a very high clinical suspicion or suggestive symptomatology. The sensitivity of the anti-deaminated gliadin is lower than that of endomysium or TTG, but still plays a role, especially in patients who have a selective IgA deficiency. We prefer doing anti-deaminated gliadin IgG in children younger than 2 years of age, because oftentimes their IgG is positive first before the IgA positivity occurs. And it's just important to remember that isolated positive anti-gliadin is usually not associated with celiac disease, or however, if the symptoms are suggested, we do suggest that a biopsy is still performed. So serological pitfalls. Now you've done all the bloods and the interpretation, but there are just a few things that we should be aware of. Always test the total serum IgA in your patients, and if it's less than 0.2 grams per liter, the patient is known with an IgA deficiency. The serological test in that instance would thus be false negative. Also keep in mind patients on immunosuppressive drugs, because oftentimes patients with celiac disease as other autoimmune diseases and could be on immunosuppressive drugs, and patients already on a strict gluten-free diet or with very low levels of gluten in their diet can have false negative results. Although we say that positive TTG and EMA is associated with a high probability of celiac disease, low levels of TTG can also be seen in other conditions. To call something seronegative, the clinician should have performed a combination of testing, so antibodies against TTG, EMA, and the deaminated gliadin peptide before it is deemed negative. If you are still unsure, you can consider doing genetic testing for HLA-DQ2 and DQ8, and also refer to a gastroenterologist for endoscopy and biopsy if you are in doubt. If everything is taken into consideration and there's still symptoms, and there's also villus atrophy, other diagnoses except celiac disease should also be considered. A very important thing to remember that there is variation among testing methods, and technical and methodological factors might affect the reported accuracy of diagnostic tests. We are always suggest that the same laboratory be used with the same assays to prevent inter-assay variation, and the serology often depicts the severity of your villus atrophy. So I'm quickly going to run through the histology. It's not my forte, but I'll try to explain it. On the left-hand side, you'll see a healthy villus mucosa where there's no lymphocytic infiltrate in the lamina propria, whereas in celiac disease, you'll see villus atrophy and a lot of lymphocytes infiltrating that area, depicting this pro-inflammatory state happening in the gut. It is known to be the gold standard for confirming your diagnosis, and to avoid sampling bias, multiple biopsy samples is required. Celiac disease can be patchy, and you could be taking a biopsy from the one area that is not affected. So histologists will also report the histological finding according to the Marsh classification. So in broad terms, the Marsh classification is divided from type 0 to type 3C, and it looks at the length of the villus, the duodenal villus, the depth of the crypt, as well as the infiltrates of lymphocytes in the lamina propria. So what are the diagnostic criteria for making the diagnosis of celiac disease? In children, the European Society for Pediatric Gastroenterology, Hepatology and Nutrition updated their diagnostic guidelines in 2020, where they stated you can actually omit an invasive biopsy in cases where the antibody levels, the TTG, is 10 times that of the upper limit of normal, as well as a positive endomysium antibody on a second blood sample. Their colleagues, however, the North American Society of Pediatric Gastroenterology, Hepatology and Nutrition, do not feel the same, and they suggest that an endoscopy is always performed even in children, and especially for those cases where a differential diagnosis should be considered. In adults, we still consider the diagnostic criteria to be positive serology as well as characteristic histological changes on endoscopy, and the criteria for Marsh should be at least a 3A to C. There are various studies now looking at biopsy sparing algorithms to prevent invasive procedures. However, there's still a lot of controversy around this because the gluten-free diets could play a role, as well as missing other causes of gastrointestinal symptomatology. So diagnostic dilemmas is real, and I'm just going to walk you through three possibilities. People with potential celiac disease can have positive serology, but on histology, there's no duodenal villus atrophy, and the histology is classified as a Marsh 1 or 0. It is important to note that 15 to 45% of these patients will progress to develop celiac disease, but it is suggested to continue them on a gluten-containing diet just because of the major impact that a gluten-free diet has on a patient's lifestyle. Regular follow-up and a repeat biopsy is recommended, and as soon as symptoms start, you should consider discussing the possibility of going gluten-free with your patient. Borderline cases is very rare and is seen in less than 10% of patients in clinical practice. And this is where the patient is symptomatic, but the serology is negative and histology shows villus changes. In these cases, you have to consider, is it actually a seronegative celiac disease, which literature reports to be less than 2% of cases. HLA-DQ2 and DQ8 typing can help in these cases to differentiate. You should also be aware of discrepancies between serological testing, inter-lab variability, inter-assay variability. And then refractory disease is seen when the patient still has severe symptoms and proven gut damage even after following a strict gluten-free diet for more than 1 year. In these cases, the clinician should consider, could there be chronic gluten contamination that the patient is not aware of, that is consuming food that actually contains gluten? Or is there maybe a clonal T cell infiltration in the gut? And is it maybe a pre-lymphoma state? So 30 to 50% of patients in the pre-lymphoma state will go on to develop a T cell lymphoma within 5 years. Patients with homozygous for HLA-DQ2 often suffer from refractory disease, and it's also important to consider that there could be a second pathology in play, a microbiome, other infections, or other sinister causes of gut problems. So what is the differential diagnosis of celiac disease? So when a biopsy was performed and the serology was positive and your histology supported it, the diagnosis of celiac disease can be comfortably made. But when you are not sure the serology is negative or the Marsh criteria was less than a 3, it's important to note that you should consider other causes. Food allergy, especially wheat allergy or even a wheat intolerance, could be the cause of patients presenting with GI problems, other autoimmune enteropathies, bacterial overgrowth, infections, giardia, and other post-gastroenteritis, viral infections. You should exclude lymphoma, a GI lymphoma, tropical sprue, or Zollinger-Ellison syndrome, where the patient produces excessive amounts of gastric acid and presents with peptic ulceration. So how can you as a clinician increase your diagnostic accuracy? So from a histological point of view, it's preferable to take multiple biopsies, at least one from the bulb of the duodenum and at least 4 from the second and the third part of the duodenum. A gluten-containing diet before you do a biopsy or serology will increase your diagnostic accuracy. And a gluten challenge is often not necessary in most cases, but may be considered in patients where there are doubt and when the patient is already following a strict gluten-free diet. HLA typing can also be performed to help with the negative predictive value. It is important to note that a gluten challenge should preferably not be performed in children younger than 5 to 6 years of age or those in their pubertal growth spurt. What is a gluten challenge? So for a gluten challenge, the daily gluten intake should contain at least the normal amount of gluten advised, which amounts to 15 grams per day. That equates to a slice of toast a day, and the patient should be counseled that this gluten challenge should be continued for a minimum of 2 weeks and preferably 6 to 8 weeks before any conclusions can be reached. During this time, anti-tissue transglutaminase IgA or IgG, if the patient is IgA deficient, monitoring can be instituted, and as well as symptom monitoring of the patient, how they feel. And it's important to note that the patients should be told that during this gluten challenge, there will be a comeback of their symptoms if it is celiac disease. If a patient then does not experience any symptoms and there's no seroconversion of the antibodies on a diet containing normal amounts of gluten within at least 2 years, you can exclude celiac disease with a reasonable degree of certainty. However, I would still suggest that repeated biopsies should be taken to prevent a delayed relapse that happens often later in life. In symptomatic patients with high levels of anti-TGG levels of more than 10 times the upper limit of normal, as well as verified by endomysial antibodies, and who are HLA-DQ2 and DQ8, you can consider omitting histological testing. Follow-up of these patients are indicated, even if they are on a gluten-free diet, to look for clinical improvement of their symptoms, as well as normalization of their celiac-specific antibody levels, which takes up to a year. So you have made the diagnosis of celiac disease. What to do now? So a lifetime gluten-free diet should be instituted. Regular symptom follow-up and improvement and normalization of your antibodies should occur if the patient is adhering to this gluten-free diet. What is gluten-free and what makes a product to be gluten-free? According to the FDA, it is when an item contains less than 20 parts per million of gluten or less than 20 milligrams per kilogram. Just to put it into perspective, that a crumb of bread or the tip of a ballpoint pen of flour equates to 10 milligrams of kilograms. So oats is usually well tolerated by patients with celiac disease, although it is important to note that some cultivars can contain celiac T-cell activating sequences, and those patients will have an inflammatory response and a relapse of their symptoms. I've said this before, that you should have a normalization of your celiac-specific antibodies if the patient adheres to his gluten-free diet strictly. So the challenge in a gluten-free diet, it's easy to prescribe a gluten-free diet, but the clinician should remember the reality and the difficulty as well as the financial implication of being on a gluten-free diet and the costs of gluten-free food, and leaving the patient with the diagnosis and the treatment without considering the impact on their daily lives or taking a holistic approach to the management is the main cause of patients relapsing and increasing their morbidity and mortality. The inaccurate labeling of foods is a big problem, as well as dining out. In our children and our adolescents, social pressure is becoming more and more. And it's important to remember that supplements, vitamin supplements, as well as certain medication can contain gluten. Even products such that is used for the stabilizing properties like ice creams, soups, dressings, soya sauce, and even cosmetic products contain low amount of gluten. Patients on a gluten-free diet often have a lower fiber intake and they present with bowel irregularities. They can have weight gain as well as disordered eating, and this should all be taken into consideration. Due to the challenge of being gluten-free for the rest of your life, new research and novel therapies have been invented, and everywhere in the pathogenesis of celiac disease, a therapy has been prevented to prevent that step in the immunological activation of your immune system. This image was taken from the Frontiers in Nutrition in 2020, and it just shows you that from the intake of gluten up to the T cells and the B cell production of antibodies, therapies are being researched. The most widely reported strategy in lowering celiac disease pathogenesis involves the use of probiotics, which exerts a protective effect on the gut mucosa and the microbiota, and also it has the potential to help digest this gluten polypeptides. There's a new therapeutic vaccine that is also in research stages, and it works almost on the same principle as allergy desensitization, where the vaccine consists of 3 gluten peptides, and it's supposed to induce a tolerogenic response in celiac disease patients by building up a resistance to gluten peptides. There are polymers that sequesters the gluten before it can be absorbed into the gut mucosa. Zonulins, inhibiting zonulins, which is responsible for increasing the intraepithelial junctions and the absorption of gliadin into the lamina propria, and then the anti-inflammatory drugs by blocking the pro-inflammatory cytokines in the gut was also being researched. Genetically modified gluten, that it's not broken down into gliadin, is also being looked at. So in essence, a dietitian should be consulted that is well-versed in gluten-free. The social well-being of the patient should always be taken into consideration, and well as an education on a gluten-free diet. It's important to note that supplementation is often necessary in these patients as they suffer from long-term effects of malabsorption, especially your iron deficiency, your B12 deficiency, and that monitoring these patients by using serology, the TTG-IgA, 2 to 3 monthly until normalization is reached up around 2 years. Although not All clinicians will advise a repeat biopsy. It is shown in the literature that it could be beneficial, especially in patients over 40 years of age or if they are still symptomatic. So the long-term risk of celiac disease is that there's an increased risk of lymphoma, especially your T-cell lymphomas, and in patients in the 7th decade of life, and it incurs a very poor prognosis. It's often seen in patients with refractory celiac disease not responding on a gluten-free diet. There's also a risk of a small bowel adenocarcinoma, as well as respiratory and cardiovascular diseases. So there's still a lot we don't know about celiac disease, and I think the main one is why not everyone that is positive for HLA, DQ2 or DQ8 have celiac disease. It's a very common allele, but not all of us will go on to develop celiac disease. What environmental factors will play a role in the diagnosis, as well as prenatal factors? What is maternal smoking, high maternal gluten consumption, has been seen in some studies to increase the diagnosis of celiac disease, as well as a shift in the microbiome associated with antibiotic use and recurrent infections. Some studies showed that breastfeeding your infants for longer or introducing gluten at around about 4 months of age will decrease the incidence of celiac disease. These are all very small studies and nothing has been proven definitely. So as we near the end of our presentation, I quickly have to talk to you just about the other possibilities, and that is reactions to wheat and gluten that is not celiac disease. So the clinician will be confronted with the patient with the history or the symptomatology, the gastrointestinal symptoms, and attributes it to consumption of wheat or gluten, and the clinician should have a sound approach to working up these patients. So on the right-hand corner, we've gone through the symptoms suggestive of celiac disease and how we test for it. But on the left, I just want to show you that if you are suspecting a wheat allergy, the first step would be to consider either skin prick testing or IgE-based testing to wheat or gluten. And if that is positive, to go on to do the allergen component testing. If your IgE-based testing is negative, that does not exclude an allergy to wheat, and a delayed or a basophil-mediated allergy should still be considered, and basophil activation test or CAS test can be performed. If this is positive, a basophil-mediated wheat allergy can be diagnosed, and if it's negative, even in the celiac disease side, a food challenge or gluten challenge can be experimented with, where if the patient is symptomatic after ingesting gluten or wheat, but all the serology and the histology and the allergy testing is negative, a probable diagnosis of a wheat intolerance or wheat sensitivity can be made. This is just a nice table summarizing the differences between these three entities, with the interval between the exposure of the gluten and then the onset of symptoms. In celiac disease, it's very insidious symptoms and non-specific, and often patients present in an atypical manner over weeks and chronically over years, whereas in gluten sensitivity, it's usually hours to days after ingesting gluten that the patient will present with severe gastrointestinal discomfort. Wheat allergy can take minutes up to hours, as well as you should always remember the delayed immune response. So the pathogenesis in celiac disease is an autoimmune disease, and allergy is usually IgE mediated or basophil mediated, and gluten sensitivity does not involve the immune system. Symptomatology is very similar across the three entities, and that is where your testing and a good history comes into play. Complications in celiac disease, I've mentioned before, can be dire, whereas in wheat allergy, depending on which component you are allergic to, can constitute severe systemic allergic reactions, even anaphylaxis, whereas in gluten sensitivity or intolerance, it's often only the discomfort that would be your greatest concern. So let's get back to our case study that we presented at the start, our 52-year-old female patient. She then had an endoscopy which showed severe villus atrophy. The histology classified it as a Marsh criteria 3C. the total IgA deficiency was confirmed with levels less than 0.2 grams per liter, and her endomysium IgG testing was positive. She had a tissue transglutaminase IgG of more than 10 times the upper limit of normal, and a diagnosis of celiac disease was made. Patient was started on a gluten-free diet and had improvement of all these symptoms within 3 months. So the take-home message is that patient awareness and self-reported reactions to wheat and gluten are on the increase, which is fueled by the global marketing of gluten-free products, as well as the access to information on the internet. And it's essential that every clinician be familiar with wheat-related reactions and have a rational diagnostic approach to these patients. Patients can not only present to the general practitioner, but as we see in the symptomatology, that they can present to a physician, the neurologist, the dermatologist, gynecologist, and even to the psychiatrist. And if you don't remember anything about tonight's presentation, I wish that you would remember the last slide, and that is how to work up patients suspected of celiac disease, and that includes your serology, which is also always important to do your total IgA levels, the antibodies against tissue transglutaminase, endomysium, and as well as the deaminated gliadin peptide. Endoscopy plays a big role in the diagnosis, and then always consider wheat-related allergies and allergic workup. It constitutes IgE-based testing, basophil activated testing, as well as allergy testing. And that is my talk for tonight. Thank you so much for listening. These are some references.
Hi, sorry about that. Sorry, I missed out your reference slide, and I think that if you start again, it will go from the beginning. Okay, so I'm just going to leave that. If anyone would like the references, you're welcome to contact me. I'm sorry that you did not get a proper introduction tonight, Dr. Swanepoel, but just the audience, so that you have some background. Dr. Swanepoel is a qualified hematologist at the immunology department at Ampath Laboratories. An interesting factoid is that she completed her community service at the Institute of Aviation Medicine and spent another year there as a medical officer. Another very interesting fact about her is that she's actively involved in the immunogenetics of solid organ transplants. Dr. Swanepoel has a wide area of interest, but her foremost passion is hematological malignancies, molecular genetics, with a recent interest in transplant medicine, especially tissue typing performed by next-generation sequencing. So Dr. Swanepoel's experience across 2 pathology disciplines has provided her with a rare skill set. And I need to comment as well and thank our sponsors tonight, which are Ampath and Thermo Fisher Scientific. Thank you for making tonight possible. So I'm sorry that this is topsy-turvy and at the end of the presentation, but thank you so much for a very interesting presentation. I had no idea that celiac disease could affect fertility issues, amongst others, and you've really made it clear the importance of serologic testing. I'm going to go through some of the questions from the audience. Okay, let me just get to the chat section. Okay, how quickly do the antibiotics fluctuate after gluten consumption? Are there any other causes besides minor gluten cross-contamination in a celiac patient with repeatedly raised gluten antibodies but normal TTG levels on strict gluten-free diet with no celiac symptoms since starting on gluten-free diet? So that was a very long question, but I hope that you got all that. So basically, how quickly do the antibiotics fluctuate after the gluten consumption, and are there any causes?
I assume they mean how quickly do the antibodies, the serological or the celiac specific antibodies fluctuate after gluten consumption. And I think
yes, antibodies, not antibiotics. Yeah.
If you look at a gluten challenge, we wait at least 2 weeks before we see increase in antibodies. So I think if you've been on a gluten-free diet and you institute gluten in your diet, you should wait at least 2 weeks for your memory B cells to see those gluten antigens and produce the antibodies against the TTG, the deaminated gliadin or the endomysium. And the second part of that question was?
Are there any other causes besides minor gluten cross-contamination in a celiac patient with repeatedly raised gliadin antibodies but normal TTG levels on strict gluten-free diet with no celiac symptoms since starting on gluten-free diet?
Yes. So the literature shows that if you're not symptomatic and your tissue transglutaminase antibodies are negative, the isolated positive gliadin antibodies is often not celiac disease. And I would refer those patients for a biopsy to confirm. And if the histology also indicates that there is no atrophy and there is no mucosal damage, I would not indicate a gluten-free diet to these patients, as it is very, the quality of life, and it is very dramatic. And monitor these patients as soon as symptoms develop or there is seroconversion of your TTG and it becomes positive, then start to consider the gluten-free diet.
Okay, thank you. There is a trend to follow an autoimmune diet for patients with other autoimmune diseases like Hashimoto. This diet advocates gluten and dairy-free eating, so gluten-free and dairy-free eating. Is there any research behind this?
So I think the only research behind this is the correlation between a lot of autoimmune diseases, and it's in the autoimmune spectrum. So like I said, celiac disease is associated with a lot of other autoimmune diseases. And in type 1 diabetes, for instance, they share common HLA genetic loci. So I think the rationale behind that is that if gluten is the offending antigen in celiac disease, by excluding that, maybe you can stop the immune reaction and help then. I don't think there's definite research that shows a link between gluten or dairy-free, but there is a lot of anecdotal evidence that shows these autoimmune diets does influence and decreases the inflammatory response within the body. You should remember that there's a lot of other environmental factors and genetic links playing a role, and we don't always know all these links and how they interplay. But autoimmunity in itself, when your autoimmune system is activated, that autoinflammatory process is turned on with the autoimmune dysregulation following.
Okay. Funny that you mentioned type 1 diabetes, because the next question is, how common is type 1 diabetes and autoimmune thyroid disease in celiac?
So it is common. I don't have stats on that, but there's a definite association between the autoimmune thyroid disease as well as type 1 diabetes. Type 1 diabetes is also associated with HLA-DQ2 and DQ8 as well as HLA-DR3, which is also seen in celiac disease. So there is a genetic link.
Okay. Are there any thoughts on people who have a long-standing hyperreactivity and hyperactive immune reaction and the development of other autoinflammatory disease like scleroderma? Also, do you have any experience of cross-reactivity with diseases like breast silicone prosthesis rejection?
Yeah, so that's all in the autoimmune world. And as soon as I think that question almost follows on the previous question. As celiac disease is an autoimmune reaction, we at least know there's a lot of research being done on celiac disease, and the offending antigen is gliadin, whereas in all the other diseases, the scleroderma, we have other antigens coming into play. Whether there's a genetic link or environmental factors, or there was a viral cause that activated the immune response and triggered autoimmunity, is probably well known, but nothing proven. It is also associated, celiac disease is associated with scleroderma, with other connective tissue diseases. And I think when you have a patient presenting with a connective tissue disease and even a breast implant associated autoimmunity, one should consider and take a good clinical history and always consider that some of the symptoms could be attributed to celiac disease. And in these patients, I would definitely do a celiac disease screen, especially if there's also a family history or an HLA-DQ2, DQ8 predisposition.
Thank you. Apart from GFD, what other treatment options are available for patients diagnosed with celiac disease?
So in my one slide, I've covered a lot. So the gluten-free diet is the mainstay of treatment, and it is the only treatment that is shown a good response, and it eliminates the offending antigen. There is a lot of other therapies in the process. The one which caught my attention was the desensitization, where they give you almost like a vaccine, which constitutes a little bit of a gluten protein, and they create immunogenic tolerance. So they make your body used to gluten so that you can maybe in future tolerate gluten. And it's the same principle as patients presenting with a grass allergy or a bee allergy or a peanut allergy, where you give them little bits and small amounts of the offending allergen in order to induce immunogenic tolerance.
Very interesting. Does good celiac disease control substantially decrease risk of malignancy?
Yes. So if you're not following a gluten-free diet and the autoimmune process and the chronic inflammation in the gut is continuing, you predispose these intraepithelial lymphocytes in the gut to clonal evolution. And often these cells can undergo T-cell receptor rearrangement, and that predisposes you to T-cell lymphoma of your gut. So it doesn't happen overnight, and it's usually a chronic process, and it's seen in people often in their 7th decade, and also where they haven't followed a strict gluten-free diet. So this inflammatory response has been going on for years and years and years, and the chronic inflammation leads to clonal evolution.
During the gluten challenge, do we have to consider the fact that most normal diets contain gluten? If yes, how will that affect the challenge proceedings?
So yes, most normal diets do contain gluten, and in a gluten challenge, we assume that the patient was on a gluten-free diet before, and that's why we are trying the gluten challenge. And we don't want to overwhelm the patient with a normal diet. So we will say eat a piece of toast daily, and after 2 weeks at least, or 6 to 8 weeks, we will then monitor your serology. If it becomes positive and the patient is symptomatic, we almost can make the diagnosis of celiac disease, and then you stop the gluten-free diet or the gluten challenge immediately. So it's not to say for every meal you will have gluten, but a piece of toast should do the trick. Like I said, it takes only 20 milligrams per kilogram of gluten to initiate that immune response and trigger a relapse of celiac disease.
Does celiac predispose patients to Crohn's or ulcerative colitis?
You have not predisposed, but you have an increased risk for inflammatory bowel disease. Your risk is almost, I think I said 3.68 times higher than the general population to develop ulcerative colitis or Crohn's disease. So yes.
Okay, someone has said a tip for us GPs: difficult to manage patients do better if a rheumatologist forms part of the treatment team.
Yeah, I agree, but I think a general practitioner can manage celiac disease very well if they are informed and if they've made the diagnosis and they can follow up the patient. It's not always necessary for the rheumatologist to form part of the team. It would be better, and it's not always practical, especially in our setting in South Africa. And I think a good dietitian and a multidisciplinary approach would also be a better approach, but I think it could be managed by a general practitioner.
Okay, this is an interesting one. Do you have statistically significant studies showing the benefit of probiotics in celiac disease?
No, so I don't have statistically significant studies, but I know it's the first non-gluten-free diet therapeutic intervention that most dietitians will try, and it is thought to exert a protective effect on the gut mucosa. Whether it really works or if it really helps, I think is still to be proven. It can also cause the alteration of the breakdown of the gluten peptides. But I think as soon as the patient has that autoinflammatory response, not even the probiotics will completely cure it, because some of that gliadin peptides will still cross the intraepithelial barrier, and the immune response and the CD4 T cells will be activated in the lumina.
Okay, thank you. What is the incidence of positive TTG in your lab, which would give an indication of the background incidence of celiac disease?
So we see a lot of positive TTG levels. The important thing is that if the false negative rate is not high, but we do see it, and it's usually in patients where the total IgA is absent or it's less than 0.02, where we then will suggest that the clinician request or the patient has a TTG IgG. So we do see a lot of positive TTGs. The lower levels, and if it's isolated or not confirmed by endomysial antibodies or histology, we often say that it could not be celiac, and we would suggest a biopsy in these cases and not to treat an isolated positive deaminated Leiden antibody. But TTG is very sensitive and very specific, and is more than 95% sensitive and specific.
Okay. Regarding the different probiotics, any particular ones superior to the others, bearing in mind that we can't mention brand names?
No, I'm not aware of anyone being more specific than the other, and I think there's still a lot of research being done around probiotics, and the exact probiotics that is necessary. There's also probiotics that have a sequestering effect on the gluten, so no.
Okay. Any proof that celiac disease is associated more being born by C-section?
I think there's a bit of controversy about a C-section and natural birth as well in the autoimmunity world, and although there are studies that say that a natural birth is better, you are exposed to more of the gut microbiome and the flora of the mother, which creates a wider array of a microbiome in the infant, which could be protective. I don't think there's any definite studies that show that there's an increased incidence of celiac disease in babies born by a C-section, no.
Is a gluten-free diet harmful to other family members who might find it easier to keep a patient on a gluten-free diet if everyone goes on it? So separate food preparation hassles, how does that play into this?
So if the patient is a diagnosed celiac disease, I think it's important to involve the whole family and to have good dietary counseling and to involve the dietitian, because the patient diagnosed with celiac disease should ideally be gluten-free, and the family should be aware that obviously separate food preparation would be necessary, and as well as to avoid products which is not obviously gluten containing. For example, the instant soup packages, ice cream, all the stabilizing properties of gluten that's in products that you're not aware of, as well as looking at labeling of foods. Some foods can say that it's gluten-free, but the amount of gluten is actually above what the FDA recommends. So to answer that question, the patient would unfortunately have to be on a separate diet, or the family could consider that everyone goes gluten-free. I don't think there's a harm. There could just be a financial implication. There could be some bowel irregularities if there's a low increase or if there's a low intake of fiber. So I don't think it's an easy decision to make, and it should be discussed with the family and how it will affect their lifestyle.
I think that's great advice. And you touched on something that I was thinking, is that I believe it can be an expensive way to eat if you're not having gluten. What are your thoughts on that, or is it doable for the average family?
Yeah, so we don't want to say that everyone with a suspected celiac disease should go gluten-free. Ideally, we would like to confirm it with the diagnostic criteria before we make the diagnosis, because the treatment is going gluten-free, and like you said, it is an expensive exercise. You don't want to treat every patient coming into your practice complaining of a wheat allergy or wheat insensitivity by telling them just avoid gluten, because it's obviously easier said than done. And ideally, the clinicians, as well as especially your general practitioners, should have a holistic approach, and as well as a algorithm on how to work up these patients. First exclude celiac disease, but also consider a wheat allergy or a wheat intolerance, which does not constitute a gluten-free diet. It's just avoiding wheat and then component testing, because not all wheat allergies, IgE-based allergy testing is actual wheat. You get cross-reactive components where the patient is allergic to grass, and then he can actually tolerate wheat in the diet. So to answer your question, it is a life-changing decision, and the diagnosis should be sure.
Absolutely. This is a comment. Labeling of foods and medicinal supplements and cosmetic products is a big issue here in South Africa. There's another comment in the Q&A section. Thank you for a very thought-provoking lecture. The research in the past 10 years is dramatic, especially in the specific diagnostic tools. So that's obviously come a long way.
Yes, yes.
Thank you so much, everyone, for joining. If you have any other questions, please do type them in the Q&A only box. Does H. pylori infection increase the risk of celiac disease?
So it doesn't increase the risk. Obviously, it will influence or compromise your microbiome or your gut integrity. But celiac disease is a disease related to the antigen gluten, and that triggers your immune system, and it's an autoimmune disease, whereas H. pylori is an infection. So it's not associated with, but I think with that integrity of the gut being compromised, it can exacerbate symptoms.
Okay. Thank you so much for your time tonight. I just want to say thanks again to our sponsors, Empath Laboratories and Thermo Fisher Scientific. And on that note, if you would like to be included in our sponsors' attendance register for tonight, please type the letter Y for yes in the chat section. That's not for CPD purposes at all. It's purely for our sponsors' attendance register for their own one. Everyone is saying thank you and informative, and well done, Dr. Swanepoel. It was very interesting. Thank you so much to the audience for joining tonight. Someone did ask if the recording will be available, and yes, the recording will be available. I will find out from the presenter, being Dr. Swanepoel, tomorrow if the presentation could be provided, but that's up to her. And you will provide. Thank you. Okay, so that's a yes from Dr. Swanepoel, and you will receive a recording of this webinar in about an hour's time. So look out for that. Thank you again, everyone. Thanks, Dr. Swanepoel.
Thank you.
Our next webinar on the 6th of December, which is about NSAID prescription with PPIs. So do look out for that one as well. Take care, Dr. Swanepoel. Thanks, everyone.
Thank you. Good night. Good night.
Good night.